Well, good afternoon, everybody. It gives me huge pleasure to welcome you to this RCSLT hosted webinar on to thicken or not to thicken. That is the question. And we're going to be exploring the evidence around the use of thickened fluid with children and young people with oropharyngeal dysphagia. My name is Morag Andrew, and I am a neurodisability paediatrician working within Community Child Health Services in Newcastle and an honorary clinical senior lecturer at Newcastle University. Thanks, Elaine. So we're going to start with some housekeeping before moving on to the content of the webinar. Elaine Ashton, our CSLT host, is on hand to help you with any technical queries, and you can get in touch with her via the chat button if need be. Please do put questions to the speakers today using the Q&A button rather than the chat if you can. Both will be being monitored. The event's being recorded and the recording will be available after the event on the RCSLT webinar along with the presentation slides. So following the panel discussion, as we've mentioned, there'll be an opportunity to ask questions. But we're also going to pause in the middle of the webinar to ask you to please complete a short survey, which will take 5 minutes, if not less, to help inform future research in this area. And I'll tell you a little bit more about that as we go through the webinar today. The links to the webinar are on a QR code. Please do complete the survey if you can during the webinar, because we're really keen to get your views to help inform the work that we are planning. The survey is for paediatricians and for speech and language therapists working within NHS settings. So please don't complete it if you don't fall into that group. It gives me pleasure to introduce our speakers today. So Alex Stewart is the Speech and Language Therapy Research Lead at Great Ormond Street Hospital for Children in London. We're also joined by Rebecca Davidson, Clinical Lead Speech and Language Therapist in the Developmental Dysphagia Service in NHS Lanarkshire, Julian Welsher, Clinical Lead Paediatric Speech and Language Therapist in Newcastle upon Tyne Hospital's NHS Foundation Trust, and also by Lucy Jackman, Specialist Paediatric Dietitian at Great Ormond Street Hospital for Children, London, and I have already introduced myself. So during the webinar today, the programme is going to be as follows. So we're going to give a bit of a background as to the reasons behind this webinar, provide an overview of the evidence on the use of thickened fluids in children and young people with oropharyngeal dysphagia as it stands at the current time. If we could just pop back to the previous slide, thank you. We'll then have a case presentation and panel discussion involving the clinicians present. We'll ask you to complete a short survey informing future research, and then we'll have a Q&A session right at the end. Thank you, Elaine. So following the publication of the RCSLT position statement on the use of thickened fluids in the management of children and young people with oropharyngeal, in the management of people with swallowing difficulties last year, the National Institute of Health and Care Health Technology Assessment Programme put out a commissioned call for research looking at the discontinuation of thickened fluids in adults with oropharyngeal dysphagia. And on the back of that, the HTA approached the British Academy of Childhood Disability Strategic Research Group, which Rebecca and I are part of, to ask if the group could support the development of a vignette for a paediatric call. And through that process, it became clear that the research to be done within the paediatric population was very different to that required within the adult population. And as part of the development work, some of you may have completed a survey which helped us to define the most relevant research question for the profession, which was around the use of thickened fluids in children and young people with oropharyngeal dysphagia, but really addressing when to start thickened fluids rather than when to stop them. A commissioned call for this trial was put out in the spring of this year, and some of the speakers on this call are part of a team planning an application in partnership with the RCSLT. But beyond this, during this process of developing the vignette, it really occurred to us that perhaps not all multidisciplinary team professionals supporting children and young people with eating and drinking difficulties were quite as aware of the building controversies around the use of thickened fluids as the speech and language therapists were, and the potential value in raising awareness across the multidisciplinary team, and hence the reason for this webinar. Thanks, Elaine. So before we get started, we'd really like to understand a little bit more about who's in the room. So it would be lovely if you could take out your phones, and I think you won't need to scan a QR code, but I think Elaine is going to launch a very short poll, which is just for fun. We're not going to use this data in any other way other than for the purposes of knowing who's here. And if you would be happy to complete the poll, we'll be able to look at that together. First of all, if you could please tell us your profession, tell us where you work. Hopefully we'll be able to see the results of that in a short moment. How are we doing, Elaine? Is that coming through in terms of any results?
Yeah, I can stop the poll. Oh, I think there's a couple more people responding.
Okay.
Do you want me to just leave it a few more seconds?
Yeah, we can do that, absolutely. Just really nice for us to know who's here, because I think we may have people joining from areas and settings out with the UK, which is really exciting.
I think that's probably a couple more people responding.
I think we'll give it another 10 seconds, and then if we could have a look at the results, that would be lovely.
Okay. You should be able to see the results.
Yep, that's great. So we've got mainly speech and language therapists, a small number of paediatricians and some dietitians, and then some other professionals who will remain unknown. Looks at most people working within the NHS, but some within other settings and some overseas attendees. So that's lovely. Thank you very much. So we're going to move on now to share with you a brief overview of the research evidence on the use of thickeners, and I'm going to hand over to my colleagues Alex and Rebecca to provide that. Thanks.
Thanks, Morag. So I'm Rebecca, and I'm going to talk with Alex about the evidence. So just to remind everybody about the context to this conversation, can you move on a slide, please, Elaine? Thank you. So Royal College of Speech and Language Therapists were getting an increasing number of queries regarding the use of thickened liquids with infants, children and young people, and dysphagia clinical excellence groups started to cover this topic in more detail as increased scrutiny was taking place. As so often happens, the conversation started around therapists working with adults, but it quickly spread to the paediatric population, where we recognise the particular challenges relating to children and the developing lung. Next slide, please. So the Royal College of Speech and Language Therapy position paper on thickened fluids was presented. It was produced in 2024. So the paper and its preceding statement, they were developed in response to this as the members of Royal College requesting guidance on the use of thickened liquids. So there's a position statement which came out in 2023, the paper in 2024 and the resources, which are designed to support dysphagia practitioners associated, to help with understanding the potential benefits or the potential burdens associated with thickened liquids, and to enable clinicians to review their current practice. So whilst the position paper isn't a systematic review of the literature, it does give an overview of the current discussions around using or not using thickened fluids. And it emphasises the importance for each clinician to be aware of the current evidence base around their clinical specialism before making decisions around thickened liquids based on principles of patient-centred care. Next slide, please. So within the context of realistic medicine or realistic healthcare, shared decision-making is at the heart of our clinical work with children and families. And realistic medicine is about ensuring decisions are made in partnership with people, helping them to make the best choices about their treatment and care that's best for them as individuals. Next slide, please. So we follow the brand format. We look at the benefits, the risks, the alternatives, and the risks of doing nothing. So for questions for the families, we encourage the families to think, what are the benefits of this treatment? What are the risks of this treatment? Are there any alternative treatments I can try? And what would happen if I did nothing? And for clinicians, the brand questions still stand. Will this infant or child or young person really benefit from using this test, this procedure, or in this case, thickened fluids? Am I exposing them to risk? What alternative options have we discussed? And if I was a patient, would I consider doing nothing at this stage? And as clinicians on the floor at the moment, it can feel quite challenging to give families sufficient evidence as to the benefits and the burdens of recommending the use of thickened fluids due to the low level of research specifically related to using thickened liquids currently available. I'm going to hand over to Alex now.
Thanks, Rebecca. I'm Alex from Great Ormond Street. So I'm going to run through a really brief overview of the evidence, aiming to remind those that are familiar with this literature and to give some awareness to those who might be less familiar. So when we're considering the question of do thickened fluids work, the logical place to start is, well, do they prevent aspiration? Thanks, Elaine. So, well, yes, we have a number of studies in children with various etiologies that would indicate that thickened fluids can reduce the likelihood of aspiration in video fluoroscopy. It's not going to work for all, and the higher percentages tend to be from studies in children with more isolated impairment, so those with no underlying conditions or those with sort of respiratory swallow coordination difficulties. But certainly we have some evidence good evidence that there is a reduction of aspiration risk on video fluoroscopy. Interestingly, the mechanism of how aspiration is reduced has been investigated in bottle-fed children or in bottle feeding using an animal model. And this research indicated that actually the reduction in aspiration was related to a reduction in bolus size rather than any changes to the timing of the swallow. And that's what was affecting the change. Next slide, please. Just wanted to raise awareness of this very recent study that looked at the use of slightly thickened fluids to eliminate laryngeal penetration, not aspiration, but laryngeal penetration. And they found no difference in the frequency, but in a reduction in the volume that entered the laryngeal vestibule. The volume of barium that entered the laryngeal vestibule was reduced in just under 20% of cases. So we have some evidence that thickened fluids can reduce aspiration risk, but we know that video fluoroscopy actually isn't real life. And this isn't just reducing aspiration on a video fluoroscopy, it actually isn't an outcome that matters particularly to children or their families. Next slide, please. Actually, what matters are these important outcomes. We need to be thinking about whether the child is enjoying drinking and thinking about theirs and their family's quality of life. We need to be thinking about respiratory health, and we need to be thinking about nutrition and hydration. So let's consider the evidence looking at some of these parameters. Next slide, please. So we'll tackle respiratory first, as this is probably the reason that most people would highlight either the preservation or improvement of respiratory health as the key reason to use thickened fluids. An evaluation is complicated by the absence of a reliable measure of aspiration-related lung disease. So we have to use proxies that are non-specific to aspiration-related respiratory infection. Evidence from the team in Boston Children's Hospital shows that respiratory admissions were reduced following introduction of thickened fluids. This was for children with laryngeal penetration, not aspiration on videofroscopy. But interestingly, it was also the case for children who were treated with reduced flow rate, so just a slower flow teat. This was a non-randomized retrospective study. Kuhn and colleagues identified a 50% reduction in risk of acute respiratory infection, but only in those who had silent aspiration on a videofroscopy. For other children, there was no change, or the risk of respiratory infection actually increased. In a comparison of breastfeeding infants, so they were identified with aspirational penetration on videofroscopy, and a group were advised to continue with some breastfeeding, and another group were recommended thickened fluids, again, a non-randomized retrospective study. Some of the children in the breastfeeding group had increased neutrophils on a BAL, but there was no difference in antibiotic use or changes in chest X-ray findings. We can consider parent-reported symptoms. These are arguably really important to look at. And Cromwich and colleagues found that parents reported a reduction in symptoms during feeding, such as chestiness or rattly breathing, but it didn't equate to a reduction in respiratory infection. And there's some evidence from an animal model study that showed that increased lung inflammation with aspiration of there's higher rates of lung inflammation with aspiration of thickened water compared to unthickened water. So I think we can agree that there is some evidence that for some children there might be some respiratory improvements, but the evidence is somewhat contradictory. And we're not quite sure who might benefit and who may not benefit. So we're going to move on to nutrition and hydration. Contrary to the adult literature, there is evidence from 2 small parent-reported studies that for some children, thickening can actually increase fluid intake. But parents also described that thickened water particularly is unpalatable, so they're needing to add juice or squash to ensure adequate intake. There are 2 studies highlighting that there's a safety efficiency trade-off. This is specifically in bottle-fed children. So although aspiration was reduced during videofroscopy, the number of sucks per swallow, so the effort that the baby's making during the feed actually increased, and that there was significantly increased volume of post-swallow residue. So the children had difficulty clearing that bolus from the pharynx. Some evidence of constipation and diarrhea following prolonged thickener use, and we know that the sodium levels are quite high in some of the thickeners used in children. So again, potential benefits, but also some burdens with regard to the impact of thickeners on nutrition and hydration. Next one, next slide, please. Oh, sorry, next slide, sorry. Finally, we can consider the impact on quality of life. So a small number of studies have considered the impact on quality of life. A recent prospective study reported that 40% of parents found that the thickeners were working well, but 60% either reported that they weren't working or that were working, but they were burdensome. There's one qualitative study reporting improved sleep, presumably related to improved intake, and therefore and also related to that, increased intake was improved enjoyment, of drinking, which presumably related to an increased intake. But parents also describe an unacknowledged emotional burden for them, and that there are problems with palatability. So in some children, actually, the improved enjoyment it's not the case. Next slide, please. And then actually we need to consider that whilst theoretically simple, actually thickening is a complex intervention. It's not as simple as taking a pill once a day. We need to remember that how thickeners thicken is dependent on the type of thickener we use, the fluid that's being thickened, the temperature of the fluid, ambient temperature, the mixing methods used, and the time taken to thicken, and how long that liquid has rested. So these all add complexity to its use in the real world. And a recent study showed that many parents changed the recipe or flow rate in order to account for all of these different factors, particularly in bottle-fed children. I've said the word bottle-fed quite a lot because quite a lot of the evidence has come from the States and in that younger cohort of children. So next slide, please. Nearly there. And then just a really brief word on the quality of the evidence that we have. There are valuable but small parent-reported outcome studies. It's important to remember that all the studies looking at respiratory outcomes are retrospective, with either no control group or a non-randomized comparison group, with small numbers in each of those groups. So there are wide confidence intervals. Although there might be significant differences, actually we don't really know the extent of that difference with much precision. And we can't account for any of the many confounding variables: reflux, whether they're in nursery, whether they have a sibling, the age of the child, normal development. All of these things actually we can't account for with these retrospective studies, or and potential biases within these study designs. So that is a very rapid overview, and I'm going to hand back to Rebecca.
Thanks, Alex. Next slide, please. So following the position paper on thickened fluids, we as clinicians, we're encouraged to consider using thickened fluids as one of the tools in our management toolbox. I know that in NHS Lanarkshire, we have a position statement on the use of thickened fluids, and for the paediatric population, we've advocated judicious use of thickeners, following the ALAP principle, which is as low as reasonably practicable. And we endeavour to consider a weaning protocol as soon as clinically appropriate, such as Walter et al., which is 2017. Thank you.
Thank you very much, Alex and Rebecca, for that really helpful overview of the evidence as it stands. I'm going to pass over to Jill now to share a case with us to help put some of this thinking into real life practice. Thanks, Jill.
Thanks, Morag. So yes, I'm a speech and language therapist in Newcastle, and I have a role within the hospital leading the inpatient service that we provide at the Great North Children's Hospital, but I also have a community caseload mainly of dysphagia and children with complex needs. And I'm going to present a case. I sort of picked this one because I felt like it probably wasn't what we always think of as our typical cases, particularly where they've got an underlying diagnosis. This is a child who I was seeing without that and without a lot of medical involvement, particularly to begin with. So I'm going to introduce to you on the next slide, please. This patient Z. So he was born at term, no issues at birth. And he first came to hospital at 7 weeks, having had a blue episode at home. And he was admitted for a week and had a nasogastric tube and some oxygen to begin with. And that lasted about 3 days, I think. And then at some point in that week, they asked for a speech therapy assessment of his feeding, and he was seen both breast and bottle feeding at that point. And there was nothing to indicate a dysphagia at that point. It felt like the coughing tended to be coming after the feeding, and so could have been more related to reflux, and he was started on treatment for that. He went home. Over the next few months, he then was started by the GP on hydrolyzed milk. He was diagnosed with CMPA, but not assessed for it, I don't think. And he kept coming to hospital. So he had another 5 admissions to hospital and 5 courses of antibiotics. At a paediatrician follow-up appointment, it seemed like nothing was stopping the coughing, and he was referred to speech and language therapy to see if there was anything else going on from an aspiration point of view that could be underlying this. He had started weaning, and that seemed to be going okay. Could we have the next slide, please? So that started with a home visit, as you would expect. And he lived at home with his parents and his older brother, who was about 2, and he was already known to respiratory for wheeze. I observed the feed, and he was fed by his dad. He was using a stage 1 teat, still at 6 months. With parents reporting that they hadn't been able to move him on to anything else without him coughing more. He tended to pause a lot during the feeding. He looked quite sleepy, but he paused quite frequently. He would just take a few sucks and seem to sort of pause for a while and then go back to feeding again. His parents reported that he always sounded wet and rattly after a feed, and indeed, from the feeds I observed, he did have a few coughs at points coming off the bottle, and he did sort of have that rattly feel if you held him afterwards. Parents had felt like they'd been going backwards and forwards to lots of different health professionals and nothing was happening, and they wanted something to change. So we discussed about trying a thickener, and we used Carabel. So at that point, we thickened to roughly level 1. And then that still seemed to be causing some coughing, so it went to roughly level 2. At this point, there was no VF had been done. There was quite a long wait for that in the community, so we just started this as a trial, and I phoned several times when I could get hold of Mum to find out how things were going. And she reported that feeding was much better, that he was no longer coughing, and that they were managing to get the feeds in without feeling stressed about it. He wasn't getting distressed with feeding anymore. So that continued for a couple of months. And then he had a paediatric appointment. I wasn't at that appointment, but it was noted then that Mum had reported that she'd stopped using the thickener and felt that everything was going well. I guess that coincided at that point with him increasing his weaning diet at around 10 months. I tried to get hold of Mum a few more times and ended up discharging. And then over the summer, he then was back in A&E a few times and had another 2 courses of antibiotics for feeling chesty. He was then referred to the respiratory team who saw him. They did a chest x-ray and that looked normal, but they referred to speech and language therapy to see if there was some underlying aspiration again that might be causing this, considering he had been on thickeners and now wasn't. So this time I didn't put him straight back on thickeners. I was lucky enough to be able to get a fairly quick slot in video fluoroscopy. So that's what I did next. Thank you very much. So these are the results of the video fluoroscopy. What we could see was quite late closure of the epiglottis quite consistently, so that you've got frequent, in more than half of the swallows of thin fluid, there was penetration and mostly ejection, but one aspiration event, which I've managed to isolate on the video fluoroscopy image there. With level 1, we were also getting multiple mild penetration, some to the vocal cords though, and then similar with level 2, but no deep penetration with that. Level 3, I'm surprised I went that far, but that was less frequent penetration, but I felt that actually the bolus was bigger. That's an interesting thing compared to what we were hearing earlier, and we got some deeper penetration with that. He was completely fine with his weaning foods. Also in that time, respiratory, had more chest x-rays. When he was presenting, that seemed fine. He was referred for a bronchoscopy, which came out normal except for finding large tonsils and adenoids. He then had a sleep study, which suggested some mild OSA was occurring as well. Can I have the next slide, please? So from that, I guess we had what we could see going on in video fluoroscopy. And as the position paper might put it, was my common sense approach was to say, let's restart the thickeners. And we restarted to level 2. During that time, he was developing well. He was developing as a normal child and seemed to be much better. We had no more admissions to A&E or antibiotics. So in an appointment with respiratory, we thought we might think about whether we still need to use thickeners or not. And so he was listed for another video fluoroscopy, which was at 2 years old. And as any speech and language therapist knows, it's a fool who takes a 2-year-old to video fluoroscopy and expects them to actually drink. So this was a limited study. We didn't get half as many swallows this time. We just did level 2, then cut to the chase with 0. No aspiration noticed this time. So that was good. And so we discussed the idea of trying to reduce the thickeners to level 1. Mum then contacted a few weeks later to say that the coughing was back and she'd put him back on level 2. He was due to have his adenoids, a coagulation of his tonsils and adenoids, and it was felt like everybody just wanted to wait for that to be done to see how things were going to go with his swallow after that. During that time, he was maybe starting to drink a little bit less of the thickened water. He was probably not having very much milk at that point. He was stealing his brother's drinks quite often. So there was concerns around that. And Mum was reporting this coughing ongoing. I felt that probably the cough was just generally going on all the time, and he was being treated with inhalers for asthma by that point. But Mum did feel that he wasn't managing his drinks. We did a 3rd video fluoroscopy not long before his 3rd birthday, which showed that he had absolutely no penetration now going on with level 2. So it looked like he was getting a bit more coordinated, but with level 1 and level 0, there was still a bit of penetration going on. But by this point, he'd been on thickeners for a long time. And I think we often find that change to thin fluids in video fluoroscopy is much less controlled, and you could see that he was tipping the cup the way he would normally expect to tip it and probably getting overwhelmed. So we did a much slower, more gradual wean over the summer months last year and successfully got him off the thickeners. And I discharged him last November. He remains under respiratory for his asthma and has been fine, although I did notice that he did have a chest infection a couple of weeks ago and needed antibiotics, but that's the first one in a long time. Next slide, please. So just reflecting on this case, I've said at the top that this case is real life, and real life can be messy. So he sort of had 2 trials. He had a trial under 1 that seemed to be showing that there was some effect of using the thickeners, that things were better, the stress had gone down with parents. And I had never said at the beginning of that how long the trial would be. And parents weren't always easy to get hold of. They stopped the trial themselves at 2 months, which is probably sooner than I would have stopped it. But I think it probably coincided with the weaning and changing in diet, so that he was managing so well with his solid food that probably Mum felt he was better and wanted things to progress more normally. And then I guess the evidence then was perhaps suggesting that he was now, over the summer, he was then going back to A&E and having more antibiotics again. The VF, I guess, told us that there was a difference in the swallow when he had thicker fluids compared to thin fluids. So another reason to consider using the thickeners. From the parent point of view, I think they were very interested in the cough aspect of things. And I think we maybe had some different thoughts about that as time went on. And it was really difficult to unpick from the beginning bit with the coughing with bottle feeding to the coughing that he was just generally having as he got a bit older, and whether we were looking at 2 different things. I was going to kind of come to the panel now just to ask a few questions about this case, if that's okay. And I was going to start with you, Alex, and ask about, as a speech therapist who does video fluoroscopies, what do you think about that timing of video fluoroscopy and that use of thickeners in our interpretation of the video fluoroscopy?
Thanks, Jill. And a very interesting case to sort of reflect upon and think about. I guess the evidence from this case would suggest that actually your video fluoroscopy was quite helpful for both the speech and language therapist to understand exactly what the problem was, because picking apart coughing on clinical assessment is very difficult. Like, as you said, it's very difficult to differentiate coughing from reflux, coughing from asthma, coughing from swallow dysfunction, and that it's very useful then to have a video fluoroscopy that can say, yes, there does appear to be a risk of aspiration that would then highlight or indicate that there is potential for respiratory infection or morbidity as a result of it. So I think, and it probably helped the parents to know that there definitely was a reason for using the thickeners, and gave you as a speech and language therapist, I think, confidence to say, yes, there may well be benefit. And that the video fluoroscopy, I think, as well can help us understand why the child is aspirating. So the child, they can demonstrate aspiration, but actually we can also use the video fluoroscopy to think about, well, why is it? And is it about respiratory swallow coordination? And therefore, what strategies might be most useful, thickener or something else?
Thank you, Alex. I think it is that aspect of, should we really always be thinking about a video fluoroscopy when we put somebody on thickeners to understand if we feel they're making a difference? Why would we be doing it?
Yeah. And I think obviously not everybody has easy access to video fluoroscopy, so to a certain extent then there has to be a trial and error. But I think understanding, for me, it's about understanding the why, that you and definitely knowing that there is a swallowing problem, because it's difficult to unpick, but also what is underlying that aspiration. Why is that child aspirating? And actually, if we're doing good quality video fluoroscopy, we should be able to get a little bit of information that can help us understand that, and therefore help us to inform our decision making with the parents.
Thanks, Alex. I'm going to ask you, Rebecca, now, particularly with all the work that you've done with the position paper and within your service. I didn't do anything else. I just did the thickener. What would you consider doing, or what could I have considered doing?
I think I've noticed a real mind shift, a clinical shift in management within the community in regard to using thickened liquids. And it's taken place over the last few years in response to new and emerging evidence. So what might have happened 4 years ago, would probably change things now. So thickened liquids definitely stay in our toolbox, and they're still used with really good effect with some children. But perhaps, whereas it might have been in the past, the first thing that we went to, the first management strategy, now we would consider trials of changing other things, changing pacing, changing positioning, bolus size, cup and teat, swallowing manoeuvres with older children, considering free water protocols with some caution, increasing oral hygiene, or changing sensory factors such as chilling drinks or adding carbonation, or even just considering tube feeding. So I would agree. I think things are changing, and thickened fluids are still in our toolbox. They still have good effect, but we tend to think of other things that we can trial. And I think it's important to revisit those things clinically as well, because the children we see are developing, they're changing over time. So what works at one stage in their life might change over time. So it's important to keep that in mind too.
Thanks, Rebecca. Lucy, as the dietitian, I'm going to come to you and just ask, as part of the MDT, when you have children who are on your caseload who we've recommended thickened fluids to, what considerations do you have around that?
Yeah, so I mean, from a nutritional perspective, the thickeners can actually have quite a big impact, both in terms of how much a child is taking orally in terms of solids or, food nutrition. but also how it might impact their weight and things like that. So a lot of these thickeners are very high in carbohydrate, which means the carbohydrate load is much higher. And so there is a possible impact of sort of excessive weight gain if you're using lots and lots of thickeners and they're having sort of a high volume of formula as well. And also because they're a sort of a fiber that kind of gels within the stomach, it can kind of delay the gastric emptying a little bit. So it can also make children or infants feel a little bit more full up. So actually, if they're sort of struggling to eat good big volumes, then, you know, this can also impact that as well. One of the main things I think we see from dietetics is that a sort of fluid volume is a real big issue, although the research that Alex presented didn't really sort of echo what we see in clinical practice. I would say it's quite difficult for a lot of children to meet their fluid requirements with the addition of thickeners, and whether that's because, you know, they're just not as palatable, you know, it's a bit more hassle to have to kind of make up the liquid with the correct consistency each time. But that can then obviously have this sort of knock-on effect to sort of the GI symptoms, so potentially increasing risk of constipation. And also just how these sort of fibers and sort of these bean gums that are used in lots of the thickeners impact sort of fermentability within the gut. So sort of the colonic bacteria really likes to feed on the things like the locust bean gum that you have in products like Carabel. And so you can get symptom of gas and bloating, especially if they're kind of taken in much larger volumes. So maybe those infants who need sort of particularly thick fluids. And actually that can then make parents think that there's a sort of a food intolerance or a food allergy. And then we get this sort of vicious circle of lots of foods being taken out of the diet that maybe don't need to be. And then if we're thinking about sort of the infants or the very little ones, you know, Alex already touched on sort of the sodium content of some of these products. And they do have some extra sodium in. And again, if you're using sort of larger volumes, we're going to be increasing the sodium load for a lot of these children. So, you know, on the surface, they maybe seem like they don't impact nutrition too much. I think they can have an impact if they use maybe in the longer term, and also depending on that child's eating behaviors and, you know, feeding history. The other thing from personal experience as a dietitian, you know, can be quite anxiety provoking. You've got an infant who's on a thickened formula, you're starting them on sort of their weaning journey, but you're not sure if they're safe for any other textures. So it can be quite difficult in the diet as a dietitian if you're in the community, perhaps you don't have quite as easy access to kind of getting some advice from a speech therapist. You know, is it safe for us to progress the textures and things like that, which could potentially have this knock-on effect for delaying progression onto sort of more solid foods or bite dissolve or, you know, whatever textures we might want to move these children onto.
Thanks, Lucy. That's loads of stuff to think about there, and makes me think we should always be working jointly.
Yeah,
on these
absolutely.
Yeah. Okay. And I'm going to come to you, Morag, last, just to ask, what would you consider as the paediatrician supporting a child who's on thickened fluids?
Thanks, Jill. Well, I mean, for me, this case really highlights the importance, as you've just flagged, in fact, about the importance of multidisciplinary team working and really thinking through the potential for comorbid health conditions that might be impacting on eating and drinking and swallowing safety and efficiency. So in this case, it seems that the thickeners were helpful, but perhaps because of slowing the transit of liquid and helping with the coordination of respiration and swallowing. And in fact, it turned out that this child had quite important respiratory, upper and lower respiratory conditions that once they were optimally managed, really started to help improve the situation overall. But I guess just listening to the wider discussion, and I think really interesting from a paediatric perspective, having come at this a bit later perhaps than speech and language therapists in their thinking, just reflecting on the fact that although there are controversies and concerns around the use of thickener, the risk balance equation it's not a null equation. You know, we're using thickener because we know that aspiration events can lead to very significant and sometimes life-limiting lung scarring and bronchiectasis for a specific group of children, and we don't really understand which children are going to have that more severe end of the respiratory ill health spectrum. And so I suppose it's coming back round the thinking about careful consideration for individuals, considering the risks and benefits, but not dismissing it as an appropriate intervention following that.
Thanks, Morag. I think that's really useful. And I do wonder if I would have done that differently now than I might have done in 2021. I can't tell you because I haven't done it. But I'm going to hand back over to you, Morag, for the survey.
Thank you. Next slide, please, Elaine. So I guess amidst all of these uncertainties, the time seems absolutely right for a trial of thickened fluid in children and young people with oropharyngeal dysphagia to help us to build that evidence base on which to base our clinical decision making. And if we could have the next slide, please, Elaine, we'll just run through the call which came out earlier this year. So this the patient group for this research will be children and young people with oropharyngeal dysphagia, where the initiation of thickened fluids is being considered. So when the speech and language therapist is already considering their use within their routine clinical practice. The intervention is thickened fluids, and applicants can define and justify the exact intervention. And other interventions should continue as usual. And we've heard that there are several of those which may be suitable for an individual child. The comparator will be no thickened fluids, and other interventions should continue in that group as well. And the important outcomes, so the information that we really want to gather within this research is stipulated to be clinically relevant respiratory health outcomes, and again would be defined by the applicant group in more detail. And then there's a host of other outcomes which relate to some of the potential side effects that we've heard about during today's session. And there's a link there to the call if you want to see more detail on that. So thank you for the next slide, Elaine. So I mentioned that we plan, a number of us on this call are part of a group who plan to make an application to this funding call. And if you're a speech and language therapist or a paediatrician working within the NHS at the moment, then we'd really appreciate your help in the development of the trial design through the completion of a short survey accessed using the QR code, which you can see on the slide. And I think Elaine is going to kindly put the link in the chat as well. So the survey is consultation about future research, doesn't need ethical approval. The findings are going to be used to help inform future clinical research, including the application that I have just mentioned in collaboration with colleagues nationally and the RCSLT. We're not requesting any personal information or contact information about you, and the information will remain anonymous. So we're going to give you up to 5 minutes to complete the survey, and we'd be extremely grateful if as many of you as possible could take the time to do that. I'm just going to flag as well that if you're a student on the call, perhaps don't complete the survey at this point in time, but if we can stick to those who are qualified speech and language therapists. Thank you. So I think in the interests of allowing time for some questions, we will carry on with the Q&A part of the session. So if I can hand over to Kathleen, please, who is going to pose some questions which have come in through the Q&A to panel members. Thank you.
Thanks, Morag. We've had lots of engagement within the questions. It's not going to be possible to answer all of them, but we will look at if there are other ways that we can support kind of answering these questions in maybe some other formats. The first question is to Alex. It's around sort of a couple of questions on weaning protocols. So someone is asked, is the weaning protocol slowly reducing the thickener until you reach thin fluids, if possible, for the child? And is this in accordance with IDSI levels, or is there another method of doing it? And also in terms of more general weaning onto solids, would you consider that earlier for a child with difficulties with thin fluids?
Okay, I will tackle the first question first. So this weaning protocol is based on one single paper. It's just to bear in mind that, and it was by Walter, W-O-L-T-E-R. Can't remember the year. Rebecca mentioned it, but in that protocol you reduce by 10% every 2 weeks, I believe. So you don't follow IDSI. It's a much more gradual than going from a level 1 to a level, or a level 2 or level 3 to a level 2 to a level 1. It is a sort of graduated 10% every 2 weeks. And should the child become symptomatic at any point, you go back to, you basically stop at the last level at which they were doing well. So that's that question, very briefly. And then the other one, would we consider earlier weaning? Probably not. Be like earlier than the 6-month recommended for most children, but I guess it is something to consider, particularly if the child is not managing any fluid. If there's risk of aspiration on any fluid level, and we're really, then that's when I might consider earlier introduction of weaning solids. But I think if the child is managing, then it would probably be better to stick, although Lucy might have another opinion on that.
I mean, I think if they're getting clinically dehydrated, I think that would be a discussion, wouldn't it, between speech therapy and dietetics, and probably the medical team as well. I know that earlier someone mentioned potentially using an NG tube over using thickened fluids, and I don't know, obviously I'm not a speech therapist, but from a dietetic perspective, that can be quite difficult to then wean that child off the tube in the longer term. So, I mean, I think there's pros and cons with everything and risk and benefits with everything, but I suppose you'd have to take each case as they come, Alex, I suppose, and see what was safe for the child in terms of weaning whilst balancing their hydration and nutrition at the same time.
Right, thank you guys. The next question's for Morag and Jill. If you're trying multiple interventions at once, so for example, if you're trying thickened fluids and you're trying kind of reducing piercing the bolus, and the child is on, for example, prophylactic antibiotics, how do you know what's working? How do you know when you should be reducing the thickener?
I think this is a really good question, and honestly one that I hope to avoid, because the evidence base around the use of prophylactic antibiotics is just as lacking, really. And there was a trial recently, the Parrot trial, where we tried to, the question was posed and around the use of prophylactic antibiotics in children and young people with cerebral palsy, and actually the trial had to close early for complex reasons, including running through COVID. But it leaves us really without a solid evidence base on which to use prophylactic antibiotics. I absolutely agree that it makes it even muddier when we're trying to understand the impact of a different intervention around eating and drinking. I personally try to avoid using prophylactic antibiotics if I am concerned that a child is potentially having aspiration events which may be contributing to chest infection. So my personal practice is not to do so. But I think it goes back to having that discussion with your paediatric and respiratory colleagues and trying to come up with a pragmatic and a sensible plan. They are used, and I think others would take the view of they're just doing everything that they can to protect the chest. But to me, it's a bit contradictory to be using prophylactic antibiotics and potentially continuing with another path that may be contributing to chest infection.
I think it's about developing some stability for the child, and once you've got that stability, it's working as a team to decide, well, what are you going to drop first, and monitoring it.
Right, thank you both. The next one's for Rebecca. It's around kind of the position paper, which recommends that if a person, so a child or an adult, is on thickened fluids, that they're not discharged, and kind of the practicalities of this around service follow-up and what you would recommend.
Yeah, I think this is a wee bit of a change in practice, isn't it? That maybe in the past we would have closed a case, closed an episode of care, and yeah, the child would have gone on using thickeners perhaps for years. But the new position paper suggests that we don't do this. I think it's good guidance. We know that children change over the years, and it could be that a child that's on thickened liquids aged 5 is doing quite well and is meeting all their hydration requirements. But a young adult needs about 2 litres of fluid a day, and that can be a completely different story. So I do think we have a clinical need to review, and I think it's up to local authorities really to think how that's going to look for them. It could be speech therapist initiated, it could be parent initiated, it could be initiated with perhaps an educational review, but it's a prescribed, it's a prescription that we're using, and I think we all rationalize prescriptions that we take on a regular basis, and this is no different really. So yeah, I think it's useful, but it is a wee bit of a change in practice to go back to not discharging all of these children, and it means that we have to have an ongoing conversation with families, which is good. It's a good thing.
Great, thank you, Rebecca. The final question for now, and like I say, I'm aware there's a lot more in the chat that we will address in another forum, is for Alex, and it's around the use of boiled cooled water or the free water protocol as an alternative to thickened fluids within children.
Mm-hmm. It's a great question, and there has been no comparison studies comparing thickener versus cooled boiled water, and there has been very, very little, even less studies on the use of a free water protocol or water-only protocol in children than there has been investigation of thickener. So, but what we are, we have some evidence from animal studies that show that aspiration of water is less harmful than aspiration of thickened water. But so the answer is there isn't a good evidence base for that, and there isn't a good evidence base for thickener. However, there is, I guess, hypothetical evidence that it would be less harmful than aspirating milk, and that it is currently, and we have evidence to show that in adults it is a good option. So we're kind of extrapolating from adult data, which we do when needed. So yeah, it's work that needs to be done, and at the moment we are using it like many other things with a limited evidence base, but it particularly for children who don't tolerate thickener, don't like it, can't drink enough. It seems like a very reasonable option as an alternative in conjunction in discussion with your pediatrician or respiratory physician.
Lovely, thank you, Alex. I'm just going to hand back to you, Morag, just to close.
Thanks so much, and that is the end of our session today, which I hope people have found of interest. I really want to thank you all for joining us and for hopefully completing our survey. But I also want to thank my colleagues on the call who have contributed to the delivery of the session today, as well as the RCSLT for hosting. And also just want to flag that if you are on a site and you think that you may be interested in participating in the research project, if we are funded, then please do get in touch. I think it's okay to say Amit that RCSLT are kind of collating a list of those sites that may be interested to participate. At this point, that is all that you're sharing, an interest to participate. It doesn't commit you to anything, but please do get in touch. And so thanks once again to everybody, and enjoy the rest of your afternoon.